My name is Danny Liew. I work at Carlin in a clinical capacity and I'm a clinician on the general medical ward. I work also at the University of Adelaide mainly, and over there I'm the Dean of Medicine and the head of the Adelaide Medical School. I work in clinical epidemiology and in particular with a focus on pharmacoepidemiology and pharmacoeconomics. What that means in short is having a look at the extent to which drugs can be deployed effectively and cost effectively to improve not only health, but to make sure that use of those resources are undertaken in a very cost effective manner. An example of the work that I've been doing or have done in this area is looking at the cost effectiveness of some of the new diabetes medications. It's a group of medications called the SGLT2 inhibitors, and they're well known for the management of diabetes, but more recently there has been an interest in the role of these medications in treating heart failure. And so my work has looked at the extent to which if we were to give these new diabetes medications to people with heart failure, regardless of whether or not they have diabetes, whether or not that would be actually cost effective in the Australian setting. As it turns out, it was shown to be or suggested to be cost effective. Subsequently, that has led to the listing of these agents on the Australian Pharmaceutical Benefits Scheme for people who are eligible with heart failure. And so what that means is that people with heart failure now have another option for treatment of their heart failure in a novel use of a drug that was actually developed for another disease. So this class of agents, which were developed initially for diabetes, has shown in clinical trials to be useful to improve survival, as well as to reduce hospitalizations for cardiovascular causes. So what we're expecting now is, with the widespread deployment and the access made to Australians at an affordable price, that people with heart failure will now have less mortality and a lesser risk of actually being hospitalized, because ultimately the use of drugs to prevent hospitalization is good, because hospitalizations obviously are a lot more expensive than a drug. And so hopefully with the use of these drugs on top of existing therapies that people might have for heart failure would mean that not only is their lifespan improved, but that their symptoms and their well-being is actually improved as well. So I've been working in that area a fair bit, and then opened up this new area of research whereby we not only are trying to project and model what the impact in terms of health of reducing or removing a risk factor such as smoking, but also quantifying in terms of that person's productivity and his or her or their contribution to the economy. Because at the end of the day, if a smoker has chronic disease or has premature death, or some other condition related to their smoking that stops them from working, then actually that has an economic impact on the country as well. And so my work more recently has been to try and make some quantification, some estimation of the benefits of reducing a risk factor like smoking in terms of not only its health benefits and healthcare benefits, but also in terms of the broader economic benefits. Prevention prevents people from getting disease and then therefore becoming patients, and that's not only good for them, but it's also good for society and the healthcare system, and that means that the healthcare system can be then more efficient and there'll be less burden on that healthcare system.